morning.
Good morning, Vicky.
Good morning.
Okay, good morning and stuff. I've already started recording. We're at 9 o'clock. So I think it's time to go ahead and get started. I hope everybody, and I'm wishing you all a really happy new year. And I hope 2021 ends up being better than 2020 has for most people. And we are hopefully, several of you have asked how much is left. We are just finishing, we're doing SDGs, which is this is unit, and then we are finished. I'm not sure if we will finish today or if we will need a little bit of time next Monday to finish this out, but that's the end of where we are. And any questions? I know several of you, I've posted about the final exam. It's on the 24th through the online portal, so you all should know all of that. The other thing is just a reminder, there are 4 or 5 of you that are taking the makeup midterm tomorrow morning. You all already have your link and access. You do that directly through forms and the link that you've been sent. And I will be available online to those of you tomorrow morning taking the exam, but I won't be active. You can just message me in MS Teams. So I just wanted to kind of go through that one last time. Any questions before I get started this morning? All good? Excellent. Excellent. Okay, so we had started talking about the SDGs, and we had specifically talked about really 2 main areas under SDG. Remember the third one, which is about health and well-being. Okay, so what we're now looking at when we do this is we're now looking at we did first the NCDs, and we talked about their measurements for tobacco and physical inactivity. What else did we talk about? I'm trying to think. Blood pressure, hypertension, salt, cardiovascular meds, having access to different treatments, things along those lines. Then we did the next within that health area, we talked about maternal and child health. And we were I was rushing through at the end, and I just thought I would pick back up kind of where we were talking about. And this is just showing you some of the dates that had happened. And this was, again, remember, MDGs preceded SDGs. And so if you're looking at the slide that I have on the screen right now, what you're going to see is maternal mortality up to the point where we started the SDGs had decreased by about 45%. Remember, but what we know is it's the leading cause of death, especially in developing countries, for women, okay? The other thing we found is that contraceptive use had increased, and we wanted to continue positive family planning. And we also talked about increased growth in prenatal and skilled care delivery, that being that really important component that we need when we talk about women's health. The prenatal care becomes vitally important for decreasing risk of complications, having a healthy baby, all of those things. So these were just to show you, and it shows you going back further to 1990. If you look at this, it shows you that decrease had been steadily, let me put it this way, we had been getting better at decreasing these mortality rates over each decade, and that has continued and stuff. So we are continuing to move forward on that. Now, this is a really fun, and I hope it's going to show. This is actually a 2-minute video on the nutritional SDGs, and it puts it together much better than I can. If it does not play for you, okay, I have the video up. So what I'm going to do is I'm going to switch our screens, and if it doesn't play, I will ask you to watch it on your own. I'll give you the link at the end of class. It's also already in your syllabus. This is one of those that I just love. So let's take a look at this and see if I can share my YouTube screen. And if it lets me do that and it plays, it'll be really exciting. Okay, so let's see. Yay! Okay, so there we go. Hopefully that was a really interesting. As you can see, it identifies 4 key countries, and I would recommend that you kind of go back and look at those. It talks about malnutrition, and what I love is, again, if you look at this, it starts to show the link between, even when we talk about the nutritional components and dealing with maternal and child health, we're talking about poverty, which is, remember, one of the preceding SDGs. And we talk about poverty equating to better, or lack of poverty, better nutrition, equating to better life outcomes, things along those lines. So you start to see how all of these are very much interrelated. And I'm going to go ahead and come back to our other PowerPoint. And let's see.
I watched it escape Cybertron myself. It was dark. I watched it escape Cybertron myself. It was carrying an Autobot technology which would have won us.
So that should help a little bit. You can go back and find that. Like I said, the link is in the very beginning. Remember, in your syllabus, there were several that said YouTube videos, and under resources, and this is in there. It's also on the page where where on your syllabus it has, we're covering Unit 8, and it says YouTube video, and there's a link there. So you have it in several places to go back and access it and watch it. Besides, obviously, you can see it now through the filming of the recording of this lecture. So I'm not going to continue on that goal. This is just a summary again of, if you look back, and I go back a couple slides, this information and this information are the same, okay? So we've already discussed the effects of how many lives could be changed by having better care and reducing anemia in women, how many lives could be changed in children due to wasting or breastfeeding and stunted growth. What I specifically want to do is, from that, is we're going to actually talk about some specific vitamin and mineral issues when we talk about global health issues. The first one we're going to talk about is thyroid health. Dr. Iman, as you're very aware, and she may have already talked to you about this, spends a lot of time, and one of her interests is the issues of iodine, and iodine in children, because it lack of iodine in children leads to poor mental development and stuff. But when we look around the world, what we find is about 200 million people in the world have some type of thyroid disease. Obviously, this is an endocrine disorder and stuff. And if we look at the US, about 12% over their lifetime. And the thing is that thyroid affects metabolism. For adults, it does. For children, it really is it becomes a capacity building of their health, their actual physical knowledge. And so what I've done here, and I'm trying to see if I can show this to you a little bit better, is I'm going to blow this slide up just so you can see. And this kind of shows the regions of the world where there is poor iodine. Lack of iodine is common, if you look at it, in most of developing parts of the world and stuff like that. We've gotten better at this over the lines and things along those lines. Risk of adverse health consequences when we look in South America. We can look at severe iodine deficiencies in certain parts of North Africa, and we come back over here. When we look into the region here where we are, you can see that we don't even have the data typically. Now, what's very interesting is recently when the Ministry of Health updated their information, iodine nutrition is one thing that Jordan also is tackled very well. Okay, so while it doesn't have as big of an impact anymore in Jordan, it does have a large impact, and you would see this coming from patients that you might have in neighboring countries and do need to be aware of it from that capacity. Now that we've seen kind of the size, let's talk about it. It is the leading cause of preventable mental retardation in children. This is why it becomes important. The same way when we talk about vaccines as being a really big health issue. This is something we can supplement. Iodine typically is, we are supplementing it through salt, and through the UN and other agencies, we actually supplement iodine through rice. Okay, it's not natural in either, but we add that in, so we try to reduce the deficiency. Okay. Pregnant women who are iodine deficient should be included in the target population because it increases their risk of miscarriages, and it also lowers potential development of the child or the infant when they're born. Now, let's talk about what do you need to have, okay? The WHO estimates, and this is again, I don't want you to memorize the 2 billion people, but we look at about 285 million children who are iodine deficient globally. Okay, like I said, this is something you want to be aware of. And how do we treat it? And what is deficiency? Well, let's get into the specifics again. Remember, we're talking SDGs. So let's talk about the guidelines. We are talking about specifically needing 150 micrograms of iodine daily. If a woman is pregnant or lactating, that goes up to 250 or 290 respectively. Okay, what you need to know is we end up with what we call goiter, which is where you see that expansion in the neck with women often and stuff like that, when it falls below 25 micrograms a day. Okay, but what I really want you to take away is the average daily. This is what we're looking at. So we really want to make sure that people will get about 150 micrograms a day. Okay, that's one vitamin issue. Okay, now let's talk about vitamin A. What do you know when I say vitamin A? What do you immediately think of? Anybody want to tell me something?
Night blindness.
Night blindness. Excellent. What else? Okay. One night blindness, but that's excellent. That's really, and actually, we're going to see that vitamin A is very much linked with night blindness. You see that as my first point up here, and it affects about 50 million children. So I'm only addressing right now deficiencies that affect large parts of the population. Okay, what happens is nearly, and if you look at this, about 250,000 children become blind every year as a result of this deficiency. Again, something that is very preventable. And when we talk about children, remember we're talking about that child dependency ratio. These are disability years that we are then, if we don't get enough iodine, they don't mentally develop properly. If they don't get enough vitamin A, there's the potential for going blind. Okay, these then cause long-term disabilities that the government and society will have to figure out how to compensate, and they're no longer necessarily adding as much into society on a tax revenue base. Okay, how does the vitamin A deficiency work? Basically, it causes damage to the cornea that can lead to total blindness. Okay, and we can also talk about vitamin A leading to deficiencies in the immune system. Okay, and actually, when we talk about the immune system, we're really talking about epithelial cells. So we're talking about the immune system in the skin. So it makes us more susceptible to coming in contact with infections and disease. And we know that vitamin A supplementation has been shown to reduce child mortality rates. Remember, can anybody remember from last week on a daily basis globally about how many children die every day under the age of 5? Anybody remember that?
16,000.
1,500. That's good.
Excellent. Excellent. Exactly. 16,000. So this is we can see where all of these different components start to add in again. If we tackle these pieces, we can talk about really good childhood prevention. Now, it also, guys, I am seeing a signal on my screen saying I have, oh, there it goes, poor quality network. If it stops being able for you to see the screen, please let me know, because I did have this problem over the weekend. Okay, so vitamin A deficiency. Now, let's move on to the next deficiency. Let's talk about iron. And iron comes back to what we were talking about with anemia specifically. If I come down into this slide, what you really want to recognize is we already have seen the numbers, but we talk about a third of women and children in the world are iron deficient. Okay, besides the anemia, okay, we're looking at it's associated with maternal mortality, prenatal mortality, and mental retardation globally. So these are the associations of long-term consequences of being iron deficient. It's not daily from your diet, it's the long-term components. And when we look at iron, we definitely are talking about emotional and cognitive development. So if we don't get proper iron in children, it ends up having the same impacts that iodine does, and things along those lines. So it's really important that not only do we treat children for iron deficiency, but when we talk about moms who are breastfeeding, because remember we talked about one of the global goals is making sure that moms are given supplementation when they're breastfeeding so babies don't become iron deficient. So these are just a couple of the things we need to kind of address when we talk about this. Now, the next one, and this just goes back into anemia again, and more of the details and community support. I'm not going to ask specifics about it, but it's a fun poster to look at. Again, when we talk about I love some of the materials that the WHO puts out, because here it talks about impairs health of millions of women and children in their development. Causes, what do we see? Notice down here, these are actually giving signs and symptoms. Yeah, okay. And let me ask you, no, I'm not going to do it. Okay. We talk about integrating a plan, strengthening healthcare systems, having community support, all of those being important when we come to treating anemia. Now, let me see if I bring this down one more time. Let me go forward. We're going, wow, lots of information, lots of quick information. Yeah, some of this is not as exciting to talk about as some of the other policies. But if we do need to recognize that these all are components that go, remember, again, when we're trying to address the SDGs and mental health, these are the things we look at that help us get to that point of addressing the health issue. Iodine, and we're going to get to zinc in a minute. We're going to have iodine, iron, vitamin A, vitamin D, And this one I really do want to spend some time on, because in the Middle East, what we find is that most and a lot of women suffer from vitamin D deficiency. And how do we get vitamin D the easiest? It's being outside and getting fresh sunlight in daytime. Going outside and sitting outside for 10 or 15 minutes every day when it's sunny is the easiest way, and it's the most affordable. It's totally free. Okay, but we can talk about other things in your diet. Eggs, cheese, fortified cereals and juices, shiitake mushrooms, salmon become very important. And if I blow this up, what you're going to see is I'm going to come over here and we're going to look at specifically dairy products and what we know: a diet deficient in vitamin D, low dietary calcium and phosphorus, inadequate sun exposure, social customs. So this is why people are often low in vitamin D. And when we look at this, what we're talking about is risk for osteoporosis, especially in adult elder women, bone fractures, and in children, it's what we call rickets. And our next slide is going to show us actually what we see when we see rickets. Okay. We can talk about osteomalacia. Does anybody know the difference between osteoporosis and osteomalacia? I know I talk about this difference with third years. Okay. Have you all, and no, you're just starting anatomy. Okay. So you're starting to put the words together. Okay. What you're going to find is one is what? Porosis and
Bones
malacia.
are porous and the other one bones are soft.
Exactly. Exactly. So this is what we're talking about here. Okay. You're also, what we know that's really interesting, that's very different besides the bone problems, is when we talk about vitamin D deficiencies, it is also highly linked with or correlated with cardiovascular disease death. And what's our leading cause of death? Again, Jordan, we've got cardiovascular disease. Okay. So we look at this and we go, wow, is there a correlation there? There's obviously a correlation. And you notice I've changed the word to correlation. We don't know how it's related, but it is related. Increased risk of death. That's your relative risk. And things along those lines. Does one cause, we do not have temporal sequence for this and things like that, but it's also related to cancer deaths. And the other thing that becomes really important and something we talked about is the lack of mental health support within the healthcare systems in the Middle East. And specifically here, we can talk about vitamin D is very highly, about 50% of people with mental health and suffering from depression have vitamin D deficiencies. So sometimes just having proper diet can affect your mental health as well. And I spend with third years a whole couple of lectures talking about specifically what we call psychonutrition, which is a whole new field of psychology that focuses on the effects of different foods and different vitamins and different minerals on different emotional aspects. We have seen various correlations with very specific types of foods. And we know if we supplement those foods in the diet, it changes. It can actually decrease the depression, and it can actually reduce anxiety. It can actually change, here's interesting, it can change your levels of empathy. All of these things, there are big studies that have been going on in, it changes in Germany and Australia recently that talk about the impact of what a mother eats, not only during pregnancy, it actually affects the child's cognitive development for the first 2 years. And this is excluding the breastfeeding component. In other words, we're already taking that into effect, that mom's diet can affect the mental stability of the baby and the infant when we talk about premature. So there's lots of information coming down the road on this. It's really a really big and growing new field within the healthcare spectrum. Now, rickets, like I said, this is where we have vitamin D deficiency in children. And why it becomes important is rickets is really, like we said, Malaysia is that bone softening. Okay. And when a baby becomes weight bearing and starts to walk, if those bones are soft, what we have is the result is of this x-ray. The bones actually bend and curve. And as a result, they have they grow into an abnormal structure. Okay. It is typically found in low and middle income countries. And again, rickets is something that we do see more commonly here within the MENA region, the Middle East, North African region. Okay. How do we prevent it? Again, calcium supplements, phosphates, vitamin D, exposure to sunlight. We're very protective of our children when we take them out into strollers and things like that. But we also, while we don't want to give them sunburns and the risk of damages from that, we also do want them to get indirect, good, natural daily light. Again, this becomes really important. Using fortified foods and fortified supplements. If you notice, most of our milks that we drink are vitamin D supplemented, and that is designed to help with that component. So the next, and I think it's one of the last efficiencies I'm going to talk about, is zinc. Okay, obviously zinc is not a vitamin, but it's a mineral. And when we look at this, about a third of children in the world are zinc deficient. And you're going, why are we going to talk about zinc? Well, zinc actually really has to do with when we're zinc deficient, it puts us at greater risk. In other words, our immune system doesn't work as well. So we're talking about risk from all diseases as a result of not having sufficient zinc mineral. Okay. Specifically, we're talking about from your skin to your gastrointestinal tract, your central nervous system, your immune system, your skeletal system, and reproductive system. So you can see it affects various systems. What do we typically see? And there's increased risk for mortality in these children that are zinc deficient. Okay, so when they get diarrhea, when they get pneumonia, when they get malaria, children who are zinc deficient are less likely to be able to deal with those health issues, and they are more likely to have a higher risk of infant mortality or child mortality. Okay, zinc, how do we get it? Fortification again. But the other thing is it comes typically from proteins. So if we're talking about something locally, which would be a protein, which is a bean, which would be hummus, animal meats, and whole grains. All those multi-grain foods, not your white processed grains, but multi-grains. Oatmeal. I'm trying to think what else would be really right in that. Oatmeal, polenta, things along those lines that are whole grains would really help. So this becomes important because, like I said, again, about a third of the children, if we get proper zinc, then they're less likely to have complications from illnesses. It's less likely to become as life-threatening. So it becomes really important. Now, how do we do this? When we talk about most of these vitamin and mineral issues, we're talking about food security. So we're talking about how do we get better agricultural ways of producing more food as the population has gotten bigger. Okay, adding supplements to food after the ages of 4 months. In other words, while breastfeeding, and you've heard me advocate that. We also talk about adding fortified supplements into the food. Little baby foods like Cheerios that have all of these things. Iodization for salt. Flour is fortified with iron and zinc and folic acid and vitamin B. Powdered milk can be fortified. So you want to make sure when you look and you're buying these products that they have these fortifications in it. Okay, obviously vaccination becomes important, hygiene, water supply, and the environmental condition and not overcrowding are the best types of prevention we can have. Now, this is just an example. When I say screenings and exams for nutritional deficiencies, am I talking primary, secondary, or tertiary prevention? Roa.
Secondary.
Absolutely. We're talking secondary. So all of these are examples of different screenings we can do to detect these types of deficiencies. I am not going to ask you to memorize all of these. Okay? Again, I don't want you to, but what I want you to know is we talk about C-reactive protein. Okay? And concentrates on inflammation and infection. For micronutrient status, okay, goiter, which, like I said, is in the neck right here. And we look at this for iodine deficiencies. Hemoglobin, obviously, is measuring iron. Serum ferritin is also measuring iron. Retinol is measuring vitamin A deficiencies, okay? Folate, again, where we're talking about folate's related to our iron levels, serum transferrin, urinary iodine, and the night blindness assessment, vitamin D deficiencies. For those of you that are interested in finding out exactly what the screening involves, each one of these, if you notice, is hyperlinked. You can go back in and you can go in and you can see what exactly do they do? What are the biomarkers? What are the needs? I've just put it up here as a nice way to kind of introduce you to some of the exams and how we do those screenings and what they are measuring and what they are finding. So you're welcome to explore these further and things like that. I would say that the two that I would be, most of them you'll recognize because you already know what iron and hemoglobin are, and it kind of gives it away. Retinol, being vitamin A, is the thing you learn. We look for retinol, typically as you get older, you look for retinol in a moisturizer for your skin, which is vitamin A and stuff. So that's kind of interesting. And the C-reactive protein. C-reactive protein we also measure quite often. It's used as a measurement when we talk about risk for cardiovascular disease. Okay, so that kind of deals with the first part of nutritional components. Now we're going to shift gears, and what we're going to talk about next is we're going to talk about injuries. And I know over the semester you all have had lots of questions, and we've kind of come back and forth several times when we look at the relationship of injuries to are they NCDs? Like I said, what we've typically done now is we've kind of separated it as a separate category. They're not infectious diseases, and they're technically separate from NCDs because they have a different orientation and very different ways of prevention. So let's talk about probably motor vehicle accidents, MVAs, okay? For those of you that come into the U.S., you will learn that in medical charts, they don't write accidents or anything else, or car, they write, you will always see it written as an MVA. Trauma, MVA, this injuries. What we already know that motor vehicle accidents are the fourth leading cause of death in Jordan. What I think is interesting is when you get down here, is if you notice down here, motor vehicle accidents, or MVAs, are the largest contributor to global, notice not medical disease, surgical disease. So they contribute the largest part of care for needing surgeries. Okay? According to the WHO, there are more than 3,500 MVA-related deaths occurred daily, and that's a global daily piece. If we go back to Jordan, I think, what was it? I was actually citing this in a document, 2 days ago. This year was just over 20, for 2020, was just over 2,200. I know, it's all, you're like, are you sure those numbers are right? Yes, that's why I had to think about it. 2,200 deaths in Jordan alone related to motor vehicle accidents. Okay, globally, it's in the top 10, but it's not like Jordan is, where it's typically number 4. And when we look at this, they're expecting that even though Jordan has already skyrocketed to this, that globally around the world, it's going to move into the top 5, okay, over the next few years. Now, let's look specifically at Jordan, okay, since that was our goal here with the SDGs. This is going back in time, and I've got a couple slides. We're going to move forward. What this slide does is it talks about each year, and what I want you to look at is each year it gives you the number of accidents from 2009 to 2013. Okay, results in physical losses, so some type of injury. Okay, result in human losses. Here we're talking about deaths. Okay, accidents resulted in human losses. Okay, number injured, number of deaths. Okay, and what they do, and you're going to see these numbers, and they go up and down every year. It's based on year-to-year increase. So from 2008 to 2009, the death rate decreased by 8.6%. But from 2009 to 2010, it decreased by 9%. What I want you, so I'm not interested over here. What I am really interested in is when we get up here, if you notice over time, number of traffic accidents actually is coming down. But we also notice is what we see about injuries. Injuries kind of the same. What do we notice about deaths? Deaths are actually going up. So this becomes, while our number of accidents is going down, the mortality rate and those dying from bad car accidents in Jordan is actually increasing, which means that we have a problem with compliance with seatbelts and other things. People are having more serious accidents than they were. In other words, the accident is typically more serious, is more likely to result in death. Okay? Now, besides seatbelts, what else do you think could be done to change kind of the results we see? What kind of policies could we make? Roa. Nobody can tell me any other kind of policies besides seatbelts that we might use to reduce, because remember, this is coming back to health policy. What are some other things we could do besides seatbelts?
Speed limits.
Speed limits, okay, and better enforcement of them, correct? Yeah. What else?
Better enforcement of the signs.
Better enforcement of signs. Sure, Hassan. This is exactly, when you say better enforcement of signs and stuff, do you all, what about, can we talk about, and can I add with signs in there, better enforcement of road rules? In other words, you don't go from the right-hand lane and turn across 3 lanes to the left. Stuff like that. I would like to add those in there because the signs and the road rules become important. And Khalid, yes, your hand.
Yeah, doctor, I think they have to make the license harder to get يعني to have it and make it for.
Should we make it hard to get?
Yeah.
Okay. What about maybe making sure you have? I know that you all recently added points to your driver's license. Yes.
Yes. Yeah.
So this is something they've done in the U.S. since for 50 years. And stuff. That is something that actually you can lose your license as a result. Exactly. So we can think about those types of things very quickly. Can we also talk about the liability? I don't know. Well, I do. You all do have a different way of dealing with it. But we can talk about criminal negligence, criminal liability for injuries and things like that. I know culturally, my understanding is that you all have to make restitution to the family if you all are the cause of the accident. That's more of a cultural component and things along those lines. Okay. But yeah, we're talking about those kinds of things. The other thing is what we're going to find is that a lot of the deaths related in car accidents are related to children. And I'm going to blow up this next slide in just a second. How many of you have family members that you know, and I don't need to see, but maybe just, or let me kind of see hands, where you have family members who are let their child ride in the front seat and they hold them. Okay? This is probably the most dangerous thing you can ever do, because that child becomes what we call a projectile. If you stop suddenly and they're not harnessed in, they are literally going to fly through that and into that window, and things along those lines. Dana.
Yes, we do
Right.
that.
Yeah.
And I would say something about the,
Yeah.
unfortunately.
Yeah. Is that all? You just wanted to say yes? You've seen that, and you've seen people do it, and people do. I mean, I can drive down the road in Amman any day and pass several families doing it. What about the use of child car seats being required? In the U.S., we require children to be in car seats up until the age of 8, or that they reach a certain amount of weight.
Mhm.
Even in the back seat, they have to have child restraint seats, and things like that up until the age of 8. They're not even allowed to ride in the front seat with a seatbelt. So we've kind of changed those components. If we look at this, what I want to do is I'll blow this up and let's go through this. What you can see is last year there were about 643 deaths, and there were 108,000 injuries. And we have the total number of accidents. If I wanted to do this, what is the ratio? Here's a little pre-final exam type of question. If I just gave you this passage here that says over the past 5 years, and it gives you those numbers, what rate can I, what more type of mortality rate can I calculate from this number? Anybody know?
A specific cause?
Case fatality.
Oh, who just said case fatality? I got a screen. Bravo. Say it again. Lean, was it you?
Yes.
Wow. Bravo. Yes. Case fatality is what we're talking about here. What do we have? We have the number of deaths from a thing over the total number of accidents. So absolutely, you can do the case fatality from that number. Okay? Now, as I keep blowing it up, let me just go ahead and show you. This is what I find really interesting. When we get here to case fatalities, this was, so I've added in the 2019. You can see that case fatality has come back down again since 2013. But it's always sitting pretty close. What's interesting to me is who's more likely to be affected. Notice that 81% of these are males, which means, guys, I hate to tell you, you're the bad drivers. Okay? When we look at the WHO traffic fatalities estimated, they're 95% that the traffic fatalities, this is what was reported, and what is the actual number is they think is somewhere around 1,913, with a range being anywhere between 1,633 and 2,193. And this really has to do with how we report with death certificates. And the estimated rate per population is 26 per 100,000 people will die from a traffic accident or an MVA. That's a pretty scary thought and stuff when we look at Jordan. When we look at how they die, okay, what's really interesting to me is it doesn't matter what kind of vehicle, or whether you're a passenger or if you're in a truck or if you're on just somebody walking. About a third of the deaths are related to pedestrians. again, go back to where we looked at the issues. Remember when we looked at the social index factors in Jordan? Things like needing safe and effective sidewalks to walk. If you have safe sidewalks, people aren't walking in the street and they're less likely to get hurt. Having proper ways to cross the street at proper points. I can tell you when I spent some time in Aruba, it's very interesting. It's a law. If a person is on the road, in other words, I'm a passenger and I start to walk out to cross the road, if I have a vehicle hit them, the vehicle am at fault. The pedestrian has the right of way. And it's so interesting because people there just stop and they drive slower because they know that pedestrians have the right of way on the island and stuff. But I think this is really interesting when we talk about whether it's in a truck or in a car or being a passenger, the distribution is about a third, a third, a third. The other thing is they came over and they looked at, when we looked at policies specifically, and they did some surveys over here, and what they found is that, guess what? Yes, we do have the policy of no seatbelt, and I'm not going to ask, actually, maybe I should do a survey. I'll try to do a survey this week. I won't take your information, but I'm curious, how many of you actually do wear seatbelts? Okay. While it's a law, if you notice here, they talk about the rate of when they've measured it to see, it's less than half. I've got news for you. I can't ride in a car without a seatbelt. It feels strange. Okay. Does that apply to front and rear seats? No, it only applies to the front seat. How much is it enforced? On a scale of 0 to 10, it's enforced not very well. Again, so not only we have a policy, but if it's not enforced, it's hard to follow. The other thing is we do not have any restrictions and child restraint laws. Okay. They say there's a restriction on children, but there's not. Okay. Is there a national law on mobile phone use while driving? Yes. Does the law prohibit? Yes. And does this apply to hands-free phones? No. If we're hands-free, we're okay. And so this gives you an idea of some of the policies. And I encourage you to look at this because to me, we can talk about saving lives is if we can get people to wear seatbelts. Let's not even talk about changing the laws right now. If everybody wears their seatbelt, the likelihood of death is drastically reduced. Okay? I think at some point I'd found a statistic that indicated that we could, I think it was like a 1 in 4, like a 25% reduction of death just from wearing a seatbelt for premature deaths in Jordan. So this gives you an idea of how important when we talk about this being a major health issue and where we need to be better at addressing health policies. Okay, now the next we'll shift gears to is infectious diseases. Much like COVID. Obviously, I did this before. Since we've dealt so much with COVID, this section is addressing other infectious diseases. Okay, when we look at this, typically remember the only leak in the top 10 causes of death besides COVID this year has been respiratory. Okay, and so the respiratory diseases, what we're really talking about, is there we go. Okay. We're talking about things that affect children and infant child mortality. We can talk about vaccines, preventing. Remember, I talked about the measles vaccine and its prevention of how many, like 15 million deaths just from measles. Universally, these vaccines, when we talk about different vaccines we can do for children, prevent at least about 1 million childhood deaths every year. Okay? The most important are the BCG for tuberculosis, the DPT, which is diphtheria, pertussis, and tetanus, pneumonia, measles, and specifically the vaccine being the MMR, which is the measles, mumps, rubella vaccine. Okay? Now, what you do need to know flat out is that half of all childhood deaths are thought to be related to pneumonia. So remember, of those 16,000 children dying every day, you can put that into 8,000 of those are pneumonia related. Okay. And here we have developed, again, a vaccine. Remember, vaccines, basic primary prevention. If we give the vaccine to the child, we are avoiding that altogether. It is really, I think, the hardest part for me to stress, and hopefully as you all did vaccine wars and really talked, is you started to find out that vaccines really are our answer. When we talk about basic public health, when we talk about primary prevention, they're the tool that cost us the least and give us the best success and prevent most of us from being exposed to certain types of mortality. Okay? The anti-vax movement, and while there are risks, and I don't say just go get a vaccine and put your arm out anytime, you do need to weigh those consequences, okay? And things along those lines. We can talk about HIV and AIDS. And what I think is really interesting is, again, this is a measure, when we talked about, remember with the NCDs and how the SDGs target that we should actually have 0 incidence of diabetes and obesity. With HIV and AIDS, they're talking about the exact same measurement, 0 incidence. As a result, 0 incidence will reduce prevalence long term. And the difference is we're focusing on young adults. This is usually where you're at higher risk for HIV and AIDS. One is due to sexual activity. The other is due to needle usage of young adults and experimentation and sharing of needles with various use of various drugs. Okay. If we talk about cases, you notice the statistic is really old. We looked at about 40 million cases globally, but what we have happen is we have about 5 million new cases every year. If I say we have about, the 40 million is incidence or prevalence?
Incidence.
The 40 million?
No, I was talking about the five.
Prevalence.
The 5 million is incidence. Excellent. So what's the 40 million?
Prevalence.
Prevalence.
Exactly. And stuff. Okay. And the thing I want you to look at is that when we look at it, it's still the 4th leading cause of death when we talk about sub-Saharan Africa. Okay. So just close by, it's still one of the top causes, the same way motor vehicles are number 4 for Jordan. For sub-Saharan African, it's still HIV and AIDS. If you noticed a few weeks ago, they actually put out a notice that for the first time they are reporting and seeing an increase in HIV cases in Jordan since COVID has come along. And I do not know what the relationship is, if there is any relationship, but maybe it's that they're doing blood testing more. I'm not quite sure what has happened. But the other thing I want you to recognize very quickly is that when we look at this, it's not gender specific. There is many females as males that get HIV. Okay, so I don't want you to think that you're not necessarily at risk. Okay, for many times it may be a partner for women. The partner may put them at risk, even though things along those lines. The other thing is we can look at the cause and effect of young adults dying from HIV and AIDS leaves about 15 million children orphaned. And that is very much a sub-Saharan issue, sub-Saharan African issue. Okay, so when they did this, what they did is they said, okay, so we want to stop incidents. What I want to show you, and again, this is really important, is typically while HIV and AIDS is going down globally, what I want you to see is that actually, ooh, that's not what I wanted to have happen. What did I do to my screen? Oh no. Why did it go black? Are you all still seeing color? It's gone totally black for me.
Yeah, same for
No.
us.
It's black for us
Oh.
too.
Okay. So give me 1 second on my technical, because this one is really important that
Doctor, can you share a PowerPoint again?
I am going to, and I'm trying to get rid of the black before I share it again. Okay. Oh, excellent. Now we'll share. Give me my option to share. Okay. What this actually shows, and the reason why I was blowing it, okay, is when we come over here, while HIV and AIDS typically around the world has been decreasing, what you need to recognize is over the last 10 years, there's been a 10% increase in HIV and AIDS within the Middle Eastern region specifically. I don't want it to, there we go. This, if we look at this across all ages, and this is specific to the Middle East, okay? This is just a graph of the Middle East showing this new HIV infections. And I think it has to do with cultural components again. People not wanting to be tested, people denying certain things. While your labor, including me, every year we have to go be HIV tested to stay in the country. In most countries, when you work foreignly as a foreign visitor, you will find that you are regularly tested. What's interesting is, like I said, Jordan requires I do this test every year. I don't typically leave Jordan, so the thing that's funny to me is if I got it, it would be from Jordan. Most other countries, you do it as a foreign visitor when you arrive, and that's the end of it, because then they recognize that you're within their base. But I do think we need to find policies that start to say we need to report these better, to keep better records. And like I said, what we found is that just in Roya News in the last month, they've talked about seeing more cases of HIV, and it's not a lot, but when you start to see an increase where you've never had any, we start to get concerned. It means that there is local infection. Obviously, it's not spreading rampant. It's not a respiratory disease. So we don't have the same mode of transmission like we do with COVID for the risk to go up as fast. But I did want you to be aware of this, okay? And when we look at this with regional concerns, let me go forward. Let's talk about treatment, okay? Remember, I talked at the very beginning last week, I talked about something called ART, which again, you see here, antiretroviral treatment, okay? And when we look at this, what we know is we need to get about less than a third of people actually get the medication needed, okay? And this is talking about we want to move from having, we've moved from having less than 1 million people getting treatment to more than 13, but we still have to do better. The other thing is we can talk about incidence rates, and we can talk about decreasing incidence. So like I said, what we see is globally, we see a decreasing incidence. In the Middle East, we start to see an increasing prevalence. Okay, so that means that we are still seeing the spread around and stuff. In other diseases, let's talk about TB, malaria. Like I said, these are, when we talk about TB and malaria, they're not diseases that we're necessarily dealing with as much in Jordan as we are dealing with in sub-Saharan Africa and other low and middle income countries and stuff. But what you do need to know is malaria. When we talk about malaria, look at this. 80% of children, the annual mortality rate is about 1 million a year. 80% of those are children. And who's the most at risk? We're talking about the world's poorest people. 40% are the poorest people, which means those, remember when we talked about economic, what we call extreme poverty, less than $1 a day kinds of things? This is that population that's at highest risk, okay? So we need to talk about health equity here when we talk about treating malaria. The Bill and Melinda Gates Foundation spends a lot of their time and focus is on these two health issues, malaria being their primary issue that they've been dealing with for the last decade, and stuff. One of the easiest things is malaria is mosquito-borne when we talk about mode of transmission. So if we talk about a way to reduce it, we talk about something as basic as having mosquito nets over beds. This becomes really important. If we talk about tuberculosis, okay, we end up with just under 2 million annually from tuberculosis. And it's not, tuberculosis is totally treatable. Actually, the WHO gives free and makes free available anywhere in the world the medications used to treat TB. The problem is the medication has to be taken for several months. People take it for a little bit of time. They start to feel better. They stop taking it. And what happens is the TB comes back. This is related to that old trick where the doctor, they say, take all your medicine. That becomes important. This is exactly what we're talking about here, because most of the deaths are related to what happens is then the TB. Remember, bacteria like to migrate and mutate. When they mutate, they become drug resistant. And what we end up with people that have drug resistant TB, and that's the complication. Okay, so we're looking at that component. The DOTS program is exactly what I'm talking about, which is the free access to the medication for malaria, drug treatment, mass sprayings. Those are policies that we can enforce to kind of change those. I also went, and these are the most recent stats I have on tuberculosis in Jordan. Okay. I'm hoping this is going to blow up. There we go. Okay. If I come over here, I'm sorry, we just went green. Okay. In 2017, you had about 500 cases. Okay. Total new and relapse, 530. Let's see if I can get that. Yeah, 537. And when we look at total new and relapse, we're looking at 525. Now, tested and rapid diagnosis was about half of them. What's really interesting, percentage with HIV. Notice that TB is an opportunistic disease. They're often related to those with HIV positive percentage with HIV status, 90% of them, pulmonary, things along those lines. Like I said, the same way when we looked at HIV, is what I find interesting is you're going, oh my God, it looks like a population pyramid again. It kind of is. Okay, notice our ages. Okay, and this is a population pyramid strictly for TB. So who's most affected? What can you tell me about that?
The working population.
Okay,
The
adult,
workforce.
young working population. When we look at the
Female.
color code, is it more males or more females? Exactly. So all of a sudden we have this very quick graphic that says we need to really work on TB identification in young working females as the risk group. Okay. And when we look over here, this then gives us the graph and shows us over years. What's actually happened is we were actually decreasing from the early 2000s up until the last few years. All of a sudden, TB starts to go back up. So we're really looking at something that this is actually increasing, and we need to stop that. Again, TB actually is very infectious. It's respiratory again. And it's one of the things that we screen for if you want to get a visa to go to the United States. As a foreigner, you have to show that you have a negative TB screening, things along those lines. Because it does spread by respiratory. It is easy to spread. It's not as easy as measles or as easy as the new COVID variants. But again, it's something that if I've been in the room, I need to be tested. So we look at those informations. Okay. Oh, I didn't mean to do that. Where's my window? Yeah. Let me share. Okay. Now, I think we're going to get through all the material today, guys. Like, oh my gosh. Now, this just talks about how this goes back to malaria. Obviously, I've already talked about the mosquito. Do you all remember you asked me a question about, did you need to know this at the midterm? And I said no. I'm just going to see if any of you all remember. You asked me about the difference between a vehicle and a vector. The mosquito here, is he a vehicle or a vector? Does anybody remember that? Or you're going, oh my gosh. I'm just curious.
Vehicle.
Excellent. Excellent. It is a
It's a
vector. Yeah, it's a living organism that spreads the disease. Perfect. And this is just showing you, I'm not going to ask these numbers, it just is kind of, but I will go ahead and blow it up. That malaria, when we talk about its impact on young infants and women, we're looking at more than almost 1 million African children under the age of 5 die from malaria. So that really is, and let me ask you that. If we're looking at a number specific to a specific region and it continually stays high, is it an epidemic, a pandemic, or an endemic?
Epidemic.
Endemic, yeah. So you can start to see where these words start to, you go, oh, I know all this. Oh, good. If you're answering these questions, you're ready for the final, okay? Malaria also contributes to malnutrition. We're talking about 50 million pregnant women each year are exposed to malaria. Again, I don't want you to know those numbers. I just want you to recognize what region. It's more likely in sub-Saharan Africa, again, because it's the poorest and all these children are dying as a result of it. Okay, so we talk about the Gates Foundation. We know that malaria contributes to maternal anemia. So there's a cause and effect relationship. Low birth weight babies. Okay, low birth weight babies are at higher risk of complications, again, from malaria. So you can see how if we develop and treat nutrition and some of these other components, that's why when they talk about no poverty, proper nutrition, and then they get to global health, and then they get to health and well-being in the SDGs, see how all of those are interrelated. If we do one, it's going to affect the others ideally in a positive outcome. Okay? I think really the last thing I'm going to talk about as far as SDGs is really the environment. And here we're talking about biofuels. By biofuels, this is something that you see happening in very impoverished areas. When I went to Thailand and Cambodia, women actually cook inside their small, literally huts, okay? And they cook using contaminants, or they cook using, this sounds funny, they use dung or animal feces after it's hardened, and they burn that. And when they burn that in those closed, contained environments, it is a huge environmental impact to the family as well as to the children in there. Biofuels count for, and doing this, and you're going, are you serious? Account for almost 1.5 million deaths every year. Okay, there's still more than 1/6 of the world's population that does not have access to clean drinking water. Industrial accidents. I know I'd mentioned the movie, what was it, with John Travolta one day in class and stuff, and saying if you want to watch some interesting movies about industrial accidents and the Beatrice case, fluorocarbons that affect the ozone layer. We've done much better at trying to deal with fluorocarbons. Okay, these are all environmental. But what I do want to say is, while we have not gotten clean water to everybody, we have improved it dramatically. And this is one of those things that needs to be done across the world. Okay, 1.9 billion people. Notice that almost 2 billion over the last couple of decades have received access now to clean water. Now we need to get that last billion or so that don't have access clean water. Okay, so they talk about a 91% global improvement 147 countries now meet drinking water sanitation. 95, though, only met sanitation goals. So while we're getting better at getting drinking water, we're not as good at getting rid of contaminated waters and having proper sanitation, cleaning of the water, what's upstream and downstream from a public health perspective. And the last slide of the whole semester, guys, okay, is talking about 5 ways to work towards our health goals. So let's put these back into, these are goals. They're not necessarily, again, you'll notice they're missing the measurements, okay? But we can talk about the things we need to work on. When we think about policies, I would say that you need to be thinking, when we think about health policies, you need to be thinking about these concepts as we think about what we're doing. Okay? Does it strengthen health status? Is it efficient and equitable? Notice, going back to the triad, this is talking about access. Okay? Placing a higher priority on health education and sanitation. Number 3 is developing cost-effective strategies that address specific health needs, things like violence, things like communicable diseases, non-communicable diseases, reproductive health, having and getting money and having the resources. And last is improving the quality of our health data. If we don't have measurable data, we don't know how to change it. And that really is important. We've got to figure out how we can change something. Like I said, something I found really interesting was when I first came into the Middle East in 2010, they really didn't want to share their data. They didn't want to measure their data. And it's hard to make a change and know what you need to do without, the numbers are never, I don't want you to put judgment on numbers. Does that make sense? The numbers are just what the numbers are. It's kind of like right now, and I'll go ahead and stop sharing the screen. It's very much like when we talk about Donald Trump in the United States and him saying that we need to do, these are fake numbers on COVID. Okay, these aren't real numbers. I've heard a couple students actually within your class ask me and say that the numbers aren't real in Jordan. The numbers are what they are. Nobody's trying to make them up. Nobody's trying to, but by knowing the numbers, we know what policies we need to do, what issues we need to address, things along those lines. So it's not good or bad. It's how we figure out what we need to do as our next step. So I really hope that you will kind of move away from thinking about, oh, this is horrible. And our gut reaction is to say, oh, that's horrible. Oh my gosh, this many people are dying from this. That's a horrible number. Well, it may be a sad number, and it may be a number you don't want to have happen. So let's figure out, how do we make a policy that changes that number? That's all this is about. And so I noticed in Roya News, what was it? I guess in the last night or so, they published something again about access and care and services. Oh, and I know it even talked about hospital beds, and it talked specifically, and I thought, oh, I'm not going to post this. The students are going to get mad at me again. It talked specifically about Jordan made a policy choice. They've now come out and said it. They could either close down the economy, which they chose not to do, or they said they could let the rates go up, which they did do, and try to build the capacity. Remember when we started class, there were just over 3,000 hospital beds. The new article in Roya, as a result of the field hospitals and everything else, your bed capacity increased to over 4,200 beds available in Jordan, of which almost 1,000 of those were ICU beds. So this was their change in their choice in policy to how to address this. So we're starting to see them now start to explain, this is why we did. We kept at this level and said we would do this based on that. Kizzy, you're okay. Stay with me. Okay. So those are my comments. And as you can see, we did get through the material. So My next question is next week. Do you want to have class and where you can ask questions as you start to prep for the exam, or do you just want to review on your own?
I think a class would be a good idea since all of them would be studying and then they will have their questions ready.
Yeah, I think yes.
Excellent. Excellent. Okay, so we will have class next week, but it will start.
Doctor, you are lagging a bit.
You're disconnecting, doctor.
Can't hear you, doctor.
Doctor, you have a problem in the connection of the internet. Yes, doctor, yes.
Oh, it brought me back. Okay, that's funny. I said any questions, and all of a sudden it goes, bad quality network, disconnecting. Hold on, we're reconnecting you. So I would say that's the sign that class is over for the day. Any questions? Everybody good? Then I will see you next week for questions and stuff.
Sure.
And like I said, that it will be a review. You all asking the questions that you want to know about for the exam. Okay. I've already posted that it's 40 multiple choice, that it's basically all new material, much like the question I just asked you from with the traffic accidents. What kind of rate can I calculate? Where I'm going to call out lean again because it stayed in my mind. She got it right. That's the kind of stuff where I'm talking about the rates kind of things. In other words, you can very quickly recognize that rate. Lean.
Doctor, when you were talking about vitamin A, I wanted to mention golden rice. Do you think it's a good idea? Like when they started putting it on the market? Even though some people claim it has problems.
You know, I think we've done some really bad things with our rice production globally. This is just you were asking very much a personal opinion. What we did is when we started to modify rice and supplement and change it, we did something where we actually taught farmers that they could get 3 cycles of rice in a year versus 2. And we are finding out that the 3 cycles actually changes some of the components of rice and the benefits. And I'm not sure that while sometimes technology is our friend, I'm not sure we're always good at understanding the impact of when we genetically modify foods. Europe has a very strong policy on no GMOs, and I think it's actually healthier than what we have done in the U.S. and some other countries. It specifically really affects Southeast Asia and all of Asia, because rice is the major staple in the diet. So it's just a personal, I'm not really sure that I've answered your question quite what you want, but I'm not really a big fan of what we've done with rice. I think I know personally, I tend to go back to using a whole grain brown rice. That's my personal preference. Any other questions? Well, I will see you next week for your questions for the review, and have a lovely first week of 2021.
Thank you.
Bye.
Bye.
Thank you,
I will
Doctor.
stop recording. Bye.
Thank you, Doctor, for anything you provide for us.
Thank you, doctor, and have a nice week.
You're welcome. It's been my pleasure. Okay, I'm going to turn off the camera, turn off the mic.
خلصت زمان.